Now, we're going to take a little bit of time to talk more about structure than content, because this type of CBT has a consistent structure, and you use the same structure for each session, even though you change the content from session to session. So I want to go through with you some of the key ideas of what a typical session is like. And we'll practice some parts of this too. As I mentioned before, this kind of CBT has both required and optional skills. And those are, in the manual, they're included in modules. So a module would have one skill in it. Some of the modules are required modules, and some of them are optional modules. I'm going to talk more later about the pros and cons of a modular therapy, but one of them is, one of the problems with the modular therapy is that you can kind of drift. And you use the case formulation to keep you from drifting, so you keep your focus on the goal of the treatment. Skill training is part of this CBT. Now, how many of you typically do skill training in sessions? If you have an individual session with an adolescent or a kid, you typically do, okay, a couple people. It's really a challenge because you have to balance skill training with the more traditional role of the therapist, which is listening, reflecting, exploring emotions, and so forth, okay? Now, for those of you familiar with dialectical behavior therapy, how do they handle skill training? Anybody know? Yeah, it's a separate group, right? So the patient in dialectical behavior therapy has an individual therapist, but then they go to a group to learn the skills training. So the skills training is separated from the individual therapy. I mean, it's used in the individual therapy, but it's not learned in the individual session. It's learned in a group, okay? So that's one way to handle this challenge. But it's a very expensive way. It would mean you'd have to have, you know, instead of one session a week, you'd have to have 2 sessions a week, or you'd have to have set up a group or something in addition to your individual work. I talked yesterday about Greg Clark's and Peter Lewinson's Coping with Depression course. That's also a skills-based group, but it doesn't have any individual therapy, okay? So that's the way they handle it. Their treatment is all skills-based, no individual psychotherapy. How does Beck handle skill training? Anybody have a sense of that in cognitive therapy? This is really a question because I don't know the answer. It seems kind of mysterious to me that somehow the therapist conveys these things to the patient, but they don't actually say, now for the next 10 minutes we're going to do skills training, okay? But, you know, if you read Beck's book, you get a sense of how they do it, but it's not real explicit. Yes?
I think there's sort of a semantics issue here with, psychotherapy.
Yeah.
And I have this issue big time when doing some coaching training and trying to determine what's the difference between a therapist and a coach.
Yeah.
And they would always compare it using a therapist as a more dynamic basis.
Right.
I think that cognitive behavior therapy, everything I've learned over the years is that psychoeducation is a part of it.
Right.
And skills training is part of psychoeducation.
Mm-hmm.
So if I'm training somebody in some relaxation or something of that sort, I think that is part of the therapy.
Yeah. I agree with that. I think you're right. I do find it challenging, though. Like if a kid comes to me with they're having a problem with their parent, I have to decide how much I'm going to listen to this and explore it, and when I'm going to say, why don't you try to do X, That's what I mean by the balance. And then and somehow I have to teach them how to do X, which I might have taught them 2 weeks before, or I might decide to teach them that day. And that's where there is a shifting in mode from more active to more passive, I think, from time to time. But I do agree with you that cognitive behavior therapy is a more active treatment on the whole than, certainly than Rogerian or psychoanalytic therapy. So you got to figure this out. So I'm throwing it out to you as a challenge in your own practice. How are you going to do this? Okay? Because if you go back to your practice and you haven't done CBT before, then on the basis of the workshop, you should be trying something different, hopefully. Okay? And one of the things that will be different will be this active kind of structuring and direction of the session. So I'm going to do some role plays around that, okay? But I just wanted to introduce the issue. Skill training is partly, skill training is partly didactic. I have to teach you a little bit about mood monitoring. I know I have to go over the thermometer and I have to go over the calendar with you to do it, but I don't want to turn it into a lecture, okay? So I want it to be active, even when I'm teaching you, collaborative. So here is the, wait a minute. This is the structure of a typical TAD CBT session. We decided to use this structure based partly on Beck, partly on Lewinson, partly on Kathleen Carroll's work with cocaine addicts, where she used this structure for CBT. The CBT session basically has 3 parts. In the first part of the session, you set the agenda for the session, and you review any homework from previous sessions. That's part 1. That should take you maybe 15 minutes, depends on, maybe less, maybe more, depends on the situation. In the middle part of the session, we did the skills training. So maybe 15 to 20 minutes devoted to basically coaching and teaching a new skill or going over a skill. And then in the third part of the session, you get back to working on the agenda items, which you may be able to work into the skill, work the skill into them. And then you come up with the new homework and you kind of summarize what happened in the session. So there's a certain flow to this that would typically characterize every session. Now, this is not, the gold standard. I mean, other people would say, do the skills training at the end, or do the skills training first. I mean, this is just the way we decided to do it, okay? We used Kathy Carroll's outline, basically. So I want to talk first about agenda setting. How many of you currently use this in your sessions, setting an agenda? 2, 3, okay, about 4 people. So I want to do a role play with somebody where I'll be the therapist and I'll work with you on an agenda, and I want you to I want the rest of you to just kind of, notice it, and we can talk about it afterwards, okay? So can I have a volunteer? We can probably use these 2 chairs up here. Okay, can I have an adolescent? Don't be too hard on me, please. Too oppositional. We're just going to do an agenda. Okay, there you go.
I was trying to get Jeff to do it. He sat there.
All right, well, we'll get him up later. All right, so Wade, I'm going to say that we're in like the 3rd session, so we've already done that initial session, and you got goals and so forth, okay? So Wade, you might recall that back in the first time we met with you and your parents, I talked with you about the way that CBT sessions work and how at the beginning I'm going to ask you what you'd like to work on during the session, okay? So do you have things you'd like to work on or talk about today?
Yeah, I'd be interested in talking about what's been going on at school.
Okay, that's good. So we can definitely put that on the agenda. Anything else?
My parents.
Your parents?
Wouldn't mind talking about that.
Okay. So we'll talk about those 2 things. Anything else?
No.
Okay. All right. I have one thing I'd like to put on the agenda, which is to go over with you a new skill that we haven't talked about before called problem solving. Okay? All right, so we basically got three things on the agenda. We'll talk about how things are going in school, things with your parents, and this problem-solving skill, okay? So tell me a little bit about what's happening in school.
Well, still getting bad grades.
Mm-hmm.
Haven't really made any progress. And I know it's only been a few weeks, but I'm still really having a tough time with classwork.
Okay. And do you have a sense of whether it's because the classwork is hard, you're having trouble concentrating, or what?
It seems like both.
Seems like both. Okay. All right, so let me hold on to that for a minute and tell me what's going on with your parents that you'd like to talk about.
Well, my parents, they're still fighting, and it still is really chaotic environment to be in, and I spend a lot of time in my room still, and I think that's pretty depressing.
Okay.
You know.
Now, I'm going to stop for a minute here. This is a pretty straightforward agenda and has 2 items on it, plus the one I put on it. Now, my question for the group is, how does this compare to the way you usually start a session? Is it similar, or different? What ways similar, or different? Similar?
I usually, and probably not rightly so, but I don't know that I tell them what I want to do as much as you did, as directly. I usually want to know what they want to talk about, and then somewhere in that process, I slide my stuff in.
That's the Beck model. That's the Beck model. That's right, yeah. Actually, in TADS, we didn't do it exactly the way I talked about it. I actually learned that more from Greg Brown, who worked with us on another project where he suggested that we actually put in to the agenda the skill, which I thought was nice because it made it kind of out in the open and, transparent. But, yeah, you're right. I mean, it's not always done that way.
Usually I ask, is there anything that you would like to discuss today? And at the end of the session, I said, is there anything that you would like to, tell me or discuss before you leave? So it's like opening and closing.
That's scary. Do that at the end. Doorknob and say,
That's when it's really going to come out. Yeah.
If it's something that it's like, doorknob therapy, I just say, okay, it sounds like this is something that we need to expand on our next session.
Mark Reinecke uses something like that. It's a little different. At the end, he will ask the kids if there was anything in the session that they, particularly found helpful or anything that they didn't like, which doesn't really open up so much a new issue but it does deal with the therapeutic alliance, So that's another way to do it. Other comments on this agenda? I'll go here first.
I was just going to say I verbally do a mood check because I would rather have our front desk be able to hand out these nice little mood things, but they don't. So I do a verbal mood check as part of the agenda, too.
That's a good idea, both a mood check and a suicide check if you have any suicide risk in the kid, to do that regularly, at least at the beginning of treatment. Yeah.
I'm just curious if you'd also want to elicit from the patient what they would prioritize. So in this case, are parents the most pressing issue, or is school the most pressing issue? Because oftentimes I find myself picking for them because, I don't know, talking about parents is so exciting. So, but in fact, the more pressing issue perhaps for the kid is the school issue. So.
And if there had been more than 2 issues, I would have had to prioritize. I thought we could probably get to 2 in this session, but often they give you 3 or 4.
I was thinking about the importance of feedback from the last session. Is there a way that we can start the session with the feedback with the last week and what happened during the week, and so that how much of it was really retained by the client, and then we can go ahead with the agenda setting?
Yeah, that's certainly a good idea. If you can You can do a little review of what happened last time. You can do the homework review then, like how did things go with the homework. Some people prefer to do that before they really say, here's what we're going to talk about this week. And I think the review of the week and the review of the homework tend to go together nicely. And some of our therapists in the TADS project did do that first, and then they went to this agenda. Others did the agenda first, and then they did the homework.
You know, you mentioned DBT, and you know, one of the reasons we do skills training in a group separate from individual in DBT is because in individual therapy, as you're trying to do skills training, your client's often coming in with the problem of the week or the day or the moment, and it consumes the entire session. And so that's one of the reasons we do it separately. But so this idea of agenda setting is really good because you're putting it out there on the table that we're going to talk about this. We're going to work on this skill today, at least for a little bit, you know, for a little bit, you know, so you can get to the problem of the week and save time for some training as well. So I think, and maybe that's why I am used to sliding stuff in, because I'm doing skills training separately from individual. So.
Thank you very much. Okay, appreciate it. You're good to go. All right. All right, now what problems have you run into in your practice when you do try to set an agenda with adolescents? Really, by far, the most common problem I've had with agenda setting is kids who don't have any agenda. They won't bring up anything. And the kid I talked about earlier who had the suicide attempt after his girlfriend broke up with him, and it wasn't a very verbal kid, he was like that all the way through treatment. No matter what I tried, I couldn't get him to bring in anything. He was unusually difficult to get to contribute to an agenda. But if they don't bring anything in for an agenda, what do you do?
I've called the parents back into the session, and for 5 minutes, I think I'm loud, right? Need this? For 5 minutes of bringing a parent in and getting kind of an update. This is especially as the younger end. We're talking adolescents, but as they get younger, even more so. And let the parents kind of set, well, remember at home this and this happened, and that usually starts some kind of little spark going in there. And then, by the way, there are times I excuse the child from the room at that point because I need to talk frankly with the parent about something. I heard something that they did in their interaction with this child, and we've set that up in the beginning, that there will be times I ask to talk to your parent alone. It's not to tell your secrets. A lot of times it's because I need to tell them to do something different. So they like it when, when I ask them to leave like that. But yeah, the parents can help you to get it stirred up.
I was just going to say, sometimes, not to be confrontational with the child, but I have access to grades and attendance and behavior through our and all therapists could too, if the parents gave you passwords to their school system things. And the students that I see know that I'm going to do that. So if they don't come up with something, I can look and review and just probe a little bit. Well, what about your grades? Here they are. Is that something you want to talk about?
Yeah. And that's especially fits in well if it's already one of the goals. If they've agreed with you on a goal that they want to work on that, then you kind of have an open door to do it.
And that was kind of what I was going to point out, is that to me it goes back to the goals, that if we've agreed to a set of goals, and it's real important to me that the goals are something that the client wants, that he or she wants to accomplish, and then I can go back to that in the agenda. I mean, you could say, well, if you have you accomplished these goals already? I mean, and if not, then there must be something that we need to work on. So you connect that back.
Good. Yeah, that's a good idea. So that brings up the general point that this treatment should be integrated, the goals and the agenda and the skills and all that. Your job as a professional is to hold that all together and make it coherent and don't get fragmented into thinking of CBT as just a bunch of techniques that you throw at people until one of them hits, You try to do it in an integrated way so the whole treatment is based on the case formulation and it flows from the goals through the skills to the outcome. And it's hard to do, but that's what you're trying to do. If you're doing CBT, part of your job is efficient time management, so that the session, you should never have ideally, you should never have a session where the kid doesn't get anything out of it. At least, you don't think they got nothing out of it, okay? The idea of the parent check-in is another one that many people use at the beginning of a session, or if the agenda stalls, to check in with parents about what has been going on and what's happened, so that you can get material there, okay? Yes. Okay, so some people, now the agenda that we did here in the role play was pretty straightforward, okay? If it's more vague, or if it's more complicated or has more parts to it, you may particularly want to write it down on paper or on it depends where your office is, but some of our therapists have like whiteboards in their offices, and they use that to write down the agenda so that they and the child can keep an eye on it while they're going through it. I mentioned that the therapist has an agenda, which is the skill training, and the patient is expected to be an active contributor to the agenda. So if a kid comes in and says, I don't have anything to put on the agenda, then my homework assignment for them that week is going to be, think of something that you can put on the agenda next week, because I want to really get them to be active. This is not a situation in which, they can listen to me lecture to them and expect to get better. It's not going to happen. Right? We found in TADS, where we had 13 sites and probably had, maybe 35 CBT therapists total, that the agenda was the most likely part of the session to be omitted. They typically did what they were supposed to do, but if they were going to miss anything, the agenda was the one that they skipped. They wanted to jump into the skill training, and they didn't wait and set an agenda. So I think some of the therapists were a little too anxious to get to the skills training. The agenda does come out of the Beck model. It doesn't come out of the Lewinson model. Lewinson is a group skill training, so there's no agenda. But in the Beck individual CBT, the agenda is very important. Okay, then other things you can do at the beginning of the session, some of these you guys have mentioned already. Briefly review what was discussed last time or in the last session. Check on how the adolescent is doing on their goals. Check their mood. You can use a questionnaire if you have one, or you can just ask them. And check on safety. Now, you have to decide on how often you think it makes sense to do this. I was in one study where they wanted us to do this in every session because the kids had been suicidal when they came into the study. So I did it for a while, and then I thought, I'm really irritating this kid, constantly asking them about if they've thought about killing themselves in the last 3 days. So I didn't do it every week, and it just didn't seem like it made sense. But I wasn't mystified about where they were. I mean, they seemed to be getting better, and I just didn't feel like I needed to ask it every single week. If they don't do their homework, you don't want to fall into the role of the teacher who gets irritated that they don't do their homework. You want to try to maintain the role of the therapist who's going to help them understand what got in the way, okay? And then problem solve how to increase the chances of completion next time. And you can also complete it during the session. So for example, if the homework is this mood monitor, and the kid comes in and they've filled out 3 boxes in an entire week when there are supposed to be 21 boxes filled out, I can spend a little time with them thinking back over the week to fill out a few more boxes, okay? So there's no reason that you can't do some of the homework in the session with them for the purpose of gaining whatever it was you gave them the homework for, right? Okay, so that's part 1 of a session, and typically that will take you 15 minutes or so to do that. okay? And it's okay if it takes you 15 minutes, that's fine. Then you go to part 2, which is the skills training. You select the skills that the therapist and patient think will help them to overcome depression, okay? And the skill training also helps you to uncover their negative cognitions. We talked about this a moment ago, even in the goal setting. If you get somebody setting goals that are very lofty and almost impossible to achieve, then you got the cognitive work laid out for you. In the same way, if you're doing homework, you're going to generate thoughts they have, like hopelessness, or wouldn't make any difference if I did it anyway, nothing's going to change. Those are thoughts that can be elicited by homework and then worked on in the cognitive part of the therapy. In fact, Beck really emphasizes that. That's why they do the homework, is to get to the thoughts so they can work on them. Skills training should take about a third of the session. It shouldn't take the whole session. And ideally, it would be integrated with what the kid puts on the agenda. In the TAD CBT manual, every skill is represented in a module. So there's a module on increasing pleasant activities, which we'll talk about after the break. There's a module on problem solving. There's several modules on cognitive restructuring. Don't identify a module as being one session. A module is a skills training piece of the manual, but you can take more than one time to learn it. I mean, how many of us learn a skill in one 10-minute exposure? It's pretty hard, right? Especially if it's really new to you. So you can spend more than one session on a module. Now, here are the modules. I'm going to just list these. The modules, some of them we've already talked about. So there's the mood monitoring, which we did. There's goal setting, which we did. The next 3 modules are increasing pleasant activities, problem solving, and cognitive restructuring. And in the current state of things, given what we know about CBT for adolescent depression or adult depression, these would be essential for most people. Now, there are interesting studies going on to see what's really essential. Like I was talking about Elizabeth McCauley's work in Seattle. She's studying a treatment that is mostly focused on increasing pleasant activities. If that treatment turns out to be just as good as a treatment that focuses on pleasant activities and problem solving and cognitive restructuring, that's going to be a big leap forward, because then we'll know that we can just do this and get the same result. It'll be a much simpler treatment. Optional modules. These are in the manual, and I'm just mentioning them now, and we'll go through most of them in the next day and a half, but we won't go through every one of them. There's a module on communication skills, one on assertion, one on social interaction, how to meet people, join groups, get involved in conversations. There's a module on relaxation that has multiple relaxation methods in it. You wouldn't want to do every one of them. You might want to do 1 or 2 of them, but they're all listed in there for you to pick from. And the one I talked about a little bit earlier on emotion regulation for the impulsive or the kids that hurt themselves. Okay. And then there's a whole set of family modules, which are they're in the same file on that disk that you got, and also online. They're in the same file, but it's a different set of pages. It says, family sessions on it. Karen Wells was the main author of this. And so there are 5 of them, one on attachment, rekindling attachment, one on family communication, one on family problem solving, one on contingency management for kids that are oppositional or disruptive, and one on parental expectations and positive reinforcement. Okay. So this is going back to session structure. So the session structure starts with the agenda and the homework review, and then the skills training. After the skills training, then, you work with the teenager on the agenda items that they brought in, ideally weaving in the new skill. If it pertains at all to the event, okay? So if they want to talk about a conflict with their parents, then, and you've only done mood monitoring, or you've only done goal setting, you might look at that event, help them deal with the event, but also weave into it how it affected their mood and how it affects their progress toward their goals, and how they might want to react in this situation to reach their goals. So you integrate it that way, okay? Prioritize the agenda items, as I was mentioning, in the same way that Linehan does in dialectical behavior therapy. Deal with anything that pertains to safety first, treatment dropout second, crises, and so forth. Make clear that you may not get to all the agenda items if there are a lot of them, but that they can be carried over to the next time. Okay. We did talk some about this while we were doing the work on goals and agenda, but it's a good idea throughout the session, and especially at the end of the session, to take time to help the kid talk about the main points covered or what they learned in the session, and to make linkages to previous sessions. Check how they feel about the session, or if anything happened that seemed helpful, particularly helpful, or in any way distressing, okay? And then at the end, you work on a new homework. Now, I joked about what to call homework, but there are some good alternatives to homework if you don't like to use the word homework. Some people call it practice, okay? Phil Kendall, in his treatment for anxiety, calls the assignments stick assignments, show that I can. Now, that was a treatment developed for younger kids, but some people like to use that acronym, stick tasks, show that I can. I saw pencils outside that have that on them, so that's a pretty good acronym to convey the idea that the purpose of the homework is to show that you can actually do the skills, okay, to try to practice them. You should choose the homework task collaboratively and base it on the skill that's being learned. There are suggested homeworks in the manual. I was asked to ask you, did anybody contact you before the conference and tell you to download the manual? You didn't get, okay, good. I didn't think so, but I actually didn't ask them to do that, but one of the other presenters did, so I want to. But you can go ahead and download it at any time. It's on the web. Just Google TAD CBT manual and you'll see it. It's a PDF file, and it's on this disk. Give the rationale for the homework, explain that homework does increase benefits. We do have evidence of that. Work to problem solve, and don't rush this part. My usual fault in homework is I do it too fast. I don't give enough time for it. Some tips for homework to facilitate completion. If you get the sense from the kid that they're not going to be very likely to do this homework, then I would spend some time bargaining with them to make it easier, to make it more likely that they will do whatever the homework assignment is, okay? It's better that they do something than nothing. And it also gives them the message that if something seems overwhelming, just do part of it. Okay, break it down into parts and do each part. As we talked about before, work with them to decide where and when they're going to do it. You could consider, if they're comfortable with this, you could consider giving them a midweek telephone call or an email or some kind of tweet, I don't know, whatever, works. If they're okay with that. If they don't want to do that, then obviously don't do it. Anticipate possible barriers. What might get in the way of doing this homework? And try to individualize it. And always ask, when you start the new session, always ask about last week's homework. Otherwise, you give them the idea that you're not really paying attention to it. So I have to confess that in my own practice, I have to usually go back to the note from the week before to see what it was I asked them to do, because I don't remember what I asked them to do from week to week. But I do put it in the note so that way I can check it. Okay, now this is not really about the structure, but it's about the process of CBT. Ideally, every session should involve a role play, even if you don't like role play. It's sort of like pleasant activities. Do them even if you don't like them. Role play is a good way to learn because it's behavioral enactment of whatever you're trying to learn. So we recommend that you do a role play in every session or almost every session. So if you're practicing communication skills, you should role play with the adolescent how to use them. I had a session a couple weeks ago with a kid who is looking for a job, and so we role played a job interview. Okay, I was the prospective employer and he was the, the applicant. And he was nervous about doing a job interview, so we did a brief role play on how he could be in the job interview, and then we talked about it, and I gave him some ideas, and we did a role play again to use the new ideas, and that was good practice for him. It'll make it easier for him to actually do an interview. If you follow learning theory and social learning theory, the sequence of skill teaching should go like this. You explain the rationale for why you're doing the skill, how it fits in with the kid's case. Then you teach the skill. Then you role play the skill. You might model it first and then ask him to do it, okay? And then you build a homework practice on the skill. So that should be the way you do skill training. Not just teaching it or didactically doing it, but enacting it behaviorally and following up with a homework. Okay? So that's the end of the part on session structure. Now, the next part is, I'm going to go over this rather quickly. This is about the parent psychoeducation sessions. These are listed in the parent manual. And they are designed for parents only. And the purpose of them is to explain to the parents what you are doing in the treatment of the kid. They're not family sessions, they're not interactive sessions, and they're not really in any way systems-based sessions. They're just psychoeducation sessions. So essentially, these sessions all have two parts. The first part is just to listen to the parents and get their take on what's happening. Get their understanding of the child's depression and also of their progress. Any ideas they may have about what's contributing to the depression. This is, beyond what you've already done in the workup. And how things are going. And then the second half is to inform them about the treatment. And as we talked about before, parents can also be seen before or after individual sessions for check-ins. I prefer to do it before because, I've had experiences where I've gone through a whole hour with a kid and then I bring the parent in and find out some big thing happened that I never heard about. So I try to get the parent in at the beginning for a check-in. In the study, we did these back-to-back with individual adolescent sessions. So this kid would have a session, and then the parent would have this psychoeducation session. So they were like 45 minutes, 30 to 45 minutes. And you may want to do them separately. You may not want to do them back-to-back with an individual session. But the advantage of this is they only had to come into the clinic once rather than coming a couple times. And these should be done in the first few weeks, week 2 or 3, and then week 4 or 5. Okay, so the first one, psychoeducation session 1, as I said, the first goal is to get the parents' views about the teenager's problems and what they think might be helpful. And the second part is to tell them about the behavioral skills that the adolescent is learning. And the 3 skills that are covered in this session are mood monitoring, which we've already done, increasing pleasant activities, which we're going to do next, and problem solving. So you just basically educate the parents about what you're doing. and how that might fit in to their child's overcoming their child's depression. Okay? Parent Psychoeducation Session 2, again, the first half of the session is to get their views and also to teach them about expressed emotion, which we're going to talk about in a minute. And then the second half is to tell them about the cognitive skills the adolescent will be learning, basically catching automatic thoughts and distortions and then challenging and restructuring negative thoughts. Okay? So let's talk for a minute about expressed emotion. There is a metaphor in the manual that we took from Michael Otto, which is about coaches. It's called the contrasting coaches story. And so it's about a kid who's playing baseball and one coach, and he goes out to catch a fly ball and he drops the ball, and the coach gets all over his case about it, okay? And, you know, tells him he's not a very good player and he needs to work harder and what did he do anyway and so forth. So it's very critical, right? And then the second coach is much more supportive. He encourages him. You know, he points out what the kid did better this time than he did the last time, even though he still dropped the ball, and he encourages him on how to go forward. So you might say the first coach is like Bobby Knight, right? Okay, and the second coach, I don't know. I'm not sure. I could say Mike Krzyzewski, but I've heard some, you know, he's not without criticism of players. There probably isn't any real coach who's quite as good as this good coach in the metaphor. Yeah.
I'm a little behavioral, but I've got the Nerf ball set in my office.
Yeah.
And I will with especially younger kids.
Yeah.
30 seconds, I'm going to be your negative voice, and I want to see how many
Okay.
baskets you make. And
All
of course,
right.
I always do the negative in the first.
Do
because
that
they're
first,
not
yeah.
sure where they are. And then the second 30 seconds are positive, encouraging. They
Yeah.
almost make 2 to 3 times as many baskets because they've got practice and
Yeah,
because they're hearing
right.
the positive things.
Right. Okay, that's a good one. That's a good way to do it. So that really enacts it. That brings it to life. Yeah. Okay. Okay, so obviously the point here is to get the parents to consider whether any of this is happening at home and whether it's affecting their child. Now, if you think that, you know, if your case formulation is such that there's zero probability that this is going on, you don't need to do this. But if you think that it might be going on, or if you've heard things from the kid about it, go ahead and do it, okay? And of course, with parents, you want to reaffirm that in every family, some negative coaching takes place, okay? So a friend of mine is on the faculty at Villanova, and he's been there a long time. He was there in 1985 when they beat Georgetown for the national title game. I'm sure you all know this, and if you don't know it, I'm here to tell you. In the North, we call them Nova. But in the South, we have to call them Villanova because there's another Nova in Miami, right? Or Fort Lauderdale. Is it in Fort Lauderdale? Is that where it is? Both, okay. Anyway, the point of my story is my friend is a priest on the faculty, and he's a complete sports fanatic. So he would go to every game and often sit on the bench. And he was there when, this was in 1985, in the round of 8, they played North Carolina. And they had to beat North Carolina to get to the Final Four. And they did not do very well in the first half. And Raleigh Massimino was the coach. So my friend John Stack, he said, yeah, he goes into the locker room with them, you know, like he's just a complete sports fanatic. So he's in the locker room with his collar on and everything, and Massimino is chewing these guys out left and right and cursing and swearing and telling them to get off their duff and, you know, they got to do better than this and blah, 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 blah. And then he noticed that Stack was over there with his collar and his black suit on, and so he turned around and he apologized to them. But the point is that everybody needs a little critical coaching sometime. They did beat North Carolina, and they went on to win the championship. So You don't want to convey to parents that, you know, it's bad to ever be critical, but you want the balance to be tilted way toward the positive. And so that's the point of this metaphor. Okay. So I'm not going to go through this in any more detail. You can get the idea. We do give parents in this second psychoed a handout on cognitive distortions, which I'll show you later when we deal with it with the kids. And we ask them if there's any cognitive distortions that they tend to use or that run in their family. Maybe they're saying things that the teens are picking up on as cognitive distortions. Criticisms that you're lazy, stupid, etc. Okay, so now, by this point in the treatment, you may be close to week 6. You've done the first session, you've done goal setting, you've done mood monitoring. You're at least at week 3 or 4. And by week 6, you should revise your case formulation based on everything you've learned, because you've had 2 more sessions with the parents now, listening to them, and you've had 3 or 4 sessions with the kid, so you know more about them than you did at baseline. And this is where you just revise and update your formulation. And maybe by now you've noticed the cognitive features of their depression that need to be addressed in treatment, even if you haven't started to address them. Maybe you have started to address them, but if you haven't yet, you've certainly seen some of them, and you've seen some of the family factors. So you basically revised the case formulation. You may also have a new appreciation for some of the strong points of the family that you want to put in your formulation. And you may be more aware of comorbid disorders. Maybe, for example, you now know that this teenager is having a hard time going out socially because not only are they depressed, but they also have social anxiety. And that wasn't, maybe that wasn't evident before. So now you know it, so you have to put that into your plan. So then you decide what modules you're going to use after you complete the basic ones, okay? So if it's a real angry adolescent or an oppositional adolescent, you may want to add in the family session on contingencies. If it's a substance abusing adolescent, you're going to have to work out a plan for either getting them substance abuse treatment or at a minimum getting urine screens. I would prefer to get them substance abuse treatment and urine screens. If it's a passive dependent adolescent, maybe you're going to need to do assertiveness training. If they're impulsive or borderline, you're going to have to do affect regulation, okay? And these are some of the family options which I mentioned, which you can, examples of options to choose from.